Good evening, everyone, and welcome to another Community Coalition Health Literacy Series. The coalition is made up of the following groups. I know we've talked about the coalition, and I just wanted to give you an idea of the organizations that are involved. They're Advocacy to Legacy, Caribbean American Society, Cricket Hall of Fame, Greater Hartford West Indian Lions Club, Jamaica Ex-Police Association, Jamaica Progressive League, New England Grand Lodge, St. Lucian Association, Sportsmen's Athletic Club, Ukrainian National Home of Hartford, West Indian Foundation, West Indian Independence Celebration, and the West Indian Social Club of Hartford. So these organizations have come together to educate and share information with our community. And this is our health series for March, and Dr. Gary Rhule will be presiding today, facilitating and presenting. And we're going to be talking about COVID strains. So I'm going to turn it over to Dr. Rhule.
Thank you, Violette. And I am going to share my screen. All right, so welcome. Good evening and welcome again to another talk on COVID coronavirus. And this evening specifically, I'm going to be talking about COVID strains. Good evening and welcome. By now, I'm sure you're familiar with the coronavirus and the spikes that you see there. And our plan for today was I'll spend about 30 minutes talking about the strains, then a Q&A and open discussion for about 20 minutes. And then the last 10 minutes, we can talk about where can I get more information. And this should go really quickly today, because I think you probably all know about the coronavirus by now. I always start with a slide to remind us where we are in terms of the global infections, the US infections, and in Connecticut. And globally, we're up to 107 million, with 2.5 million deaths. In the US, 28 million persons infected, with 500,000 persons dying from the coronavirus. In Connecticut, 283,000 persons infected, and this number says about 8,000 persons have died from it. And the Hartford County number is the number from last month, 65,000 infected, with 2,178 persons dying. That number obviously is higher. And then again, just kind of point out the fact that there are specific populations that are increased risk for not only infections, hospitalizations, and death. And the way that I kind of remember it is that persons who are Native Americans, African American, Hispanic, you're probably about twice as likely to be infected. So I kind of rounded that 1.8, 1.7 number to 2. Hospitalizations about 4 times as likely, and deaths 3 times as likely, specifically for Native Americans, Hispanic, and Black persons in the Black diaspora. What is COVID-19? It's a severe acute respiratory syndrome, coronavirus 2, also called SARS-CoV-2. It's the virus that causes COVID-19. It's an RNA virus. And this should be old hat to you because I present this every time I talk, just to kind of level set and bring us back to just understanding talking the same language. And of course, it's infected the entire globe. This you haven't seen before. So this is the SARS-CoV-2 genome. And the genome basically is just the genetic material. It's an RNA virus. This is what it looks like from the sequencing that they've done. And that brown area is where the spike protein is. And so then what the virus does, it packages the squiggly lines that you see, it packages its genome in basically a fat bubble, a lipid layer, a fat bubble. And then the spike proteins are coming off of those. Genes, as you know, contain the instructions to build parts of the virus, the envelope, the spike proteins, and other things that the virus needs to make copies of itself. And just like you and I, the virus actually wants to live and make more copies of itself, and that's really what it does. The brown section in the picture I showed you before has the genetic instructions to build the spike protein. That's how the protein actually attaches onto the respiratory, the brain, the heart, the lungs, the human tissue, and then basically enters the cells that way. So the spike protein is a thing that allows the virus to attach to human cells during the infection. And of course, we monitor, you might hear people talking about genomic surveillance, right? So they're monitoring specifically with the infections. They're seeing how the genome is changing, and specifically because the spike protein is a thing that allows the virus to enter the cell, you're also going to monitor what's going on with that specific section. Okay, so COVID strains. Viruses can constantly change as they make copies of themselves. And they do that for a couple of reasons, obviously, right? So as they're making copies of themselves, it may make a mistake, and or if it finds that it is making the host too sick or is killing the host, if you basically kill the thing that you're invading, then obviously you can't replicate. So you'll find that there'll always be mutations, and as the infection goes globally, you're going to find that there are going to be multiple strains and mutations that occur. And we've seen that in the US, and basically, I'll talk about the specific ones that have been recognized. But this is really just part and parcel of the virus replication as they try to make copies of themselves. So mutations are changes, that's what it means, in genetic code of a virus that naturally occurs over time when an animal or person is infected. A certain amount of genetic variation is expected to occur just as the SARS-CoV spreads. We know that's going to happen. Many of the mutations, though, do not affect the virus's ability to spread or cause disease. They might be doing something else. But specifically for this virus, we monitor for the key mutations to see if it's going to make it more infectious, easier to catch, resulting more infections, resulting in more hospitalizations, and resulting in more deaths. If you don't test, if you don't check for it, you're not going to know that it's actually there. So one of the things you actually have to do is the genomic surveillance to see exactly what's going on with the virus and how it's changing. So you're going to monitor changes for the spike protein as well as other parts of the genetic material that's changing. There are multiple variants that's been identified. We've been dealing with COVID-19 since the late 2019, December 2019. And what I'll talk about really just three known, there are more known variants. There is a UK variant. It's a variant called B117, and this is nothing that you have to memorize. I just put it there so that you know. So the UK variant, first recognized in the fall of 2020. It's thought to spread more easily and quickly than the other variants, and may be associated with an increased risk of death compared to the other variants. So recognized in the UK in the fall of 2020, first detected in the US in December 2020. There is a South Africa variant called the B1.351, and that's independent of the UK variant, first detected in early 2020 in October. It has some of the same mutations as the UK variant, and as of January 2021, their variants have been seen in the US as well. There is a Brazilian variant, This is a variant called P.1 or P1, first identified in early January. And this was seen in travelers coming from Brazil when they were tested at an airport in Japan. It has some of the same mutations and more that we've recognized in the previous variants. And one of the things that has been seen is that we think it might affect the ability of the antibodies, if you're infected, to recognize this particular variant. And again, as of January 2021, a couple of months ago, this has also been identified in the US. So those three specific variants, the UK, the South African, and the Brazilian variant are here. And you can basically assume that other variants, they're here already in the US. And if it's not been reported, it's just because we really haven't tested. There are other variants you probably have heard about. There's a California variant, there's a New York variant, there are other variants that are emerging. I didn't really want to talk a whole lot about those because they're still under study and emerging, and to figure out specifically what's happening to them. Again, the reason why that's important for the variants are, we kind of want to answer, does it make it more infectious? Do more people get sick? Is it going to cause more hospitalizations and or potentially more deaths? And this is really what the slide says. Why are we concerned? Are the variants going to make it more easily spread and more quickly people becoming infected? Obviously, if you have more cases of COVID-19, that means more people are going to become sick, more hospitalizations. It's going to strain the healthcare resources, and potentially you're going to have more deaths. And specifically for the populations I talked about in the several slides before, Native Americans, persons in the Black diaspora, Hispanics, our rates are much higher, so obviously we're going to be very concerned if those variants become a problem. This is, again, just another nice picture of the COVID-19 virus with the spikes there. And that thing that's twisting is, actually that's a DNA, but that's typically how the, that's just a representation of the genetic material. Okay, so, again, just assume that these variants are there. The UK, the Brazilian, the South African, it's identified in the US, it's here. For the places where they haven't talked about it, it's probably because they haven't done that genomic surveillance. And when you have a large unchecked infections, you can be sure there's going to be one coming from India, there's a California variant, there's a New York variant. You're probably going to have variants coming from places where infections are becoming unchecked. Florida, Mississippi, Louisiana, Texas, that's going to be a problem for many, many people. So coronavirus, a year and a half into this, lots of variants are here. We still have to do a lot of work in terms of prevention, proper masking, physical distancing, hand washing, and vaccines. So as of now, kind of just turning and flipping a little bit to talk about what's available in terms of vaccines, right? So there are 3 vaccines that have been approved for emergency use. The Pfizer vaccine you probably have known about, 2 doses, Moderna, 2 doses. Just last Saturday, Johnson & Johnson was approved for emergency use. It's only 1 dose. In the Q&A, we can talk a little bit more about, I know that persons have concerns about any one of the vaccines. We can talk a little bit more about what that means. But right now, 3 of them available for emergency use authorization. In terms of the variants, why this is important is because some of the vaccines, and it's still being studied, specifically with the South African variant, there's a concern that and I don't have it on here because it's not in the US, the Oxford AstraZeneca vaccine may not be effective against the South African variant. But that's why we're constantly doing the studies to kind of understand what's happening with the virus, what's going on with the variants, and will they protect you specifically against, will the vaccines protect you against the classic or the wild type coronavirus and or the variants that are known and or emerging. And we can talk a little bit more about that in the Q&A. I pulled this number from Connecticut's number. I think this was from today or yesterday in terms of persons who have been vaccinated. So those who have gotten a first dose, 773,000. Those persons who have gotten a second dose, 389,000. And this really is the Pfizer and the Moderna vaccines. And I can't tell you how many have gotten one of either, but this is really the first two vaccines that are in the marketplace as of now. So that's Pfizer and Moderna. And 300,000 is probably like 9% or 10% of the Connecticut population who would be considered fully vaccinated. Another nice picture of the coronavirus. I think just like with the last talk, I talked about, most people who get coronavirus, most people will recover. Obviously, there is also persons at risk for death from it, and many, many persons have died, as you've seen with the numbers. But there's also the symptoms that we get from what's called long COVID, where you recover from COVID, you didn't die from it, but it damages many, many organs in your body, right? So your heart, your brain, your lungs, your kidney, people on dialysis, long-term weakness, people who also have issues with psychological problems, mental health issues, post-traumatic stress, just a whole bunch of bad, I would say just nasty things that happens with this infection. You don't want this infection. I don't think I can say that enough times. You don't want this infection. So with that said, we need to get ourselves vaccinated, protect ourselves, our families, and our communities. And so one of the things that's happening currently are multiple sites are being stood up to help you with a vaccine. And I'll mention this now, and then we'll talk more about it in the Q&A. On Thursday, March 11th, I think from 4 to 9, don't quote me in the time, there's a site at the West Indian Social Club. You have to pre-register, and I think we've probably met that limit for pre-registration. But there are many other community events, clinics, community health centers, local health departments, hospitals, CVS, Walgreens, Walmart, that you can get your vaccine. All of them require you to pre-register. If you need help with getting pre-registered, of course, the West Indian Foundation, the West Indian Social Club, 211, you can call. They can get you help with being registered to get your vaccine. If you are hardy and want to do it yourself, which is fine too, you can go to VAMS online, which is vams.cdc.gov, and follow those instructions to do your pre-registration. You can ask your provider for help. Again, just keep up to date with the vaccine information. I'll talk a little bit about the state rollout plan, and then just keep engaged with us again, just to get information about what's going on with getting your vaccine and other information for coronavirus and the variants that are coming. Okay, the state, this is Connecticut's state plan. As of now, if you are 55 and above, 55 years and above, you're currently eligible to register and get your vaccine. As of March 27, they're going to expand the eligibility to ages 45 to 54. On April 12th, the expansion is from ages 35 to 44. And then as of May 3rd, ages 16 to 34. So just be very mindful of the dates that apply to you and be really aggressive and assertive to be sure that when your age shows up, you register and you get your vaccine. Key takes away, I'd say it, get vaccinated. You don't want COVID. You don't want long COVID. We obviously don't want you to die from this. And so get registered, get your vaccines. We'll answer your questions. Even when you become vaccinated, you still have to do prevention work, right? Because the vaccines prevent you from becoming very sick. It prevents hospitalization, and it prevents death from getting the vaccine. Getting vaccinated doesn't mean that you cannot carry wild type or the variant coronavirus in your body. You just won't get sick because you've gotten the vaccine. But so if you don't wear the mask, if you don't physical distance, social distance, if you don't hand sanitize, when you go around other people, you're carrying that virus and that variant, you're going to infect your family, your friends, and your community. So get vaccinated, but that doesn't mean you throw away your mask, right? So you're still going to wear those masks because you can infect other people, as well as other people can pass on that wild type coronavirus to you, as well as the variants that are there. And of course, I'll say again, keep up to date with the information and join us every second Monday of the month for more information. A nice picture of Hartford Bushnell. And I'll stop for questions and answers, and we'll talk a little bit more in the Q&A about where do you go for more information. And I'll stop sharing. That's the formal slides, my friends.
Thank you, Dr. Rhule. I had one question. When we talk about the rollout, it goes to 16 to age 34. Are they going to provide vaccines to people under 16, or do youth not need to be vaccinated?
You do, but the issue is the studies were not done in persons who were less than 16 years old. So okay. Those studies are being done now, and most likely by May, you'll have some information about the pediatric population, but that's why. Because when they did the clinical studies, I think even like Pfizer, it was 18 and above. And so 16 is really the cutoff for when the clinical studies were done. And we're still doing the pediatric population at this point.
Okay.
That's why.
Okay. Also with the vaccination, are there I know there's special groups of people that are eligible regardless of age, but are there medical conditions also, or is it just your occupation?
Right, so I think if you go to the CDC's website, every state kind of did it differently, because at one point we talked about vaccinating people who were 55 and above and or had risk factors, right? So obesity, respiratory issues, asthma, diabetes, heart disease. We kind of talked about putting those people in the pipeline, but Connecticut state plan at this point is age-based.
Okay.
Is really age-based. Other states have really done different things.
Okay.
You also recognize that because they opened schools as of March 1st, those persons, teachers, people in the school system are being vaccinated, because obviously if they're going to open school and they're going to be around, right, there are special clinics for that specific profession and persons working in the school system.
Okay. two questions. When they say age 45 to 54, will they continue to do age 55 also at the same time?
Yes, because I didn't pull up the slide because you'll find that even when they open the 75 and above, the vaccination is not 100% for that age group. And actually on the CDC's website, if you really want to drill down, you can figure out like what percentage of that age group is vaccinated. And it's definitely not 100%. If you look at specific populations, whether they're African American or Hispanic, for whether it's Hartford County or Bloomfield or West Hartford, it's not high. So you can still get your vaccine even if your age group is open, because it will still be open anyway.
Okay. Is one vaccine more effective against, say, for instance, the South African strain than another? Or do we not know?
So I don't think we quite know. Right, so in the US, the three that are approved, EUA approved, are the Pfizer, Moderna, and the Johnson & Johnson. In the UK, the Oxford AstraZeneca one is approved. And there is some suggestion that that specific vaccine is not as effective against the South African variant. The good thing, I think, about the Pfizer and the Moderna vaccine is because it's based upon the spike protein and they're monitoring the genetic code, I think you probably have a lot more flexibility in changing the vaccine to address the variants that are coming, versus something that is more labor intensive, like the Johnson & Johnson vaccine, because it's not genetic, it is based on the genetic, but it's not the same technology basically as the other two.
Okay.
But so to answer your question, so it's being studied, and if we figure out that specific variants are resistant to it, we can tweak the vaccines to address the issue.
Okay, thanks. Another question that has come in is it accurate that if two people are together and both have been vaccinated, they don't have to wear masks?
No, that would not be accurate, and I would recommend that, right? Because, well, so are you in the same household? So if you're in the same household, I mean, nobody's walking around in their same household wearing a mask. So after you become vaccinated in your household, I don't think you're wearing a mask anyway. But if somebody is going out into the workplace, into the community, and you don't really know what they're doing, they're going to parties, they're going to places where they're congregating, then really you have to make a decision. Once you come back into your household, even though you're vaccinated, you can bring the wild type virus in, or you can bring the variant in. So the answer is technically no, but you really have to monitor what you're doing. So in a household, you wouldn't have to, but if it's my friend and I don't know what they're doing on the outside, you should be wearing a mask to protect yourself.
Okay, even if you're vaccinated. Okay. I think Mr. Caswell has a question.
Yes, good evening. Just like the census, there are a lot of hesitancy in registering for the vaccine because people who are not straight. How do you approach that situation if someone is not a legal alien or legal resident, I should say, and they want to be vaccinated? Is there a special way to do that? Because I spoke to someone and they're afraid to register because they're not sure what's going to happen if they do.
So if you go to VAMS, what it asks is for just your name, your date of birth, your address, and it doesn't take any insurance information, doesn't ask if you're a citizen, if you're undocumented. That's one way. But a lot of the clinic sites allow you can call, allow you to actually walk in and do a registration that day, and that information is basically just on a paper. It's not asking if you're documented, if you're a citizen, if you're a permanent resident. It's really just taking your name, your age to be sure that you're in that group, your phone number if they need to contact you, but there's no citizen information, there's nothing like that at all.
Okay, great.
Right.
And one quick follow-up. If you have the virus, how long after the virus is gone you can be vaccinated?
That's a great question. So the recommendation is that you should wait at least 3 months after you've had the acute infection to get vaccinated. But there are some people who probably had an asymptomatic infection who didn't get sick, who are being vaccinated, right? Because you could have been sick, you know, your carrier, you had it, but you didn't know. And when you go for your vaccine, it's not like we're not drawing any blood work. They're going to ask you, are you sick today? Have you been sick in the past? But it could be that you were an asymptomatic carrier and didn't get anything. You're going to get your vaccine anyway. But if you are known to have COVID-19, you should be waiting at least 3 months before you get your vaccine. So that's really the answer to your question. You should at least wait if you're known to have it.
Can you also talk about if you're taking some types of medication? Because, you know, I'm registering people, and somebody called back today and said she got her shot, TDAP, whatever that is, and now her doctor's telling her she can't get the COVID. And I know somebody else who was scheduled for like their MS treatment, and then they were going to get their COVID, but then their doctor says, no, you can't get your COVID shot until 15 days after, you know. So can you talk a little bit about that?
Right. So when you actually go for your vaccine, they'll ask you, had you had a recent vaccine? Because, well, Tdap is tetanus, diphtheria, pertussis, and these are boosters. Well, the pertussis is a booster. And if you've gotten any vaccine, flu vaccine, any other type of vaccine, you don't really want your body trying to build up antibodies or being boosted by the vaccine that you just had, interfering potentially with the COVID vaccine. So that's why they're giving you that recommendation. If you've had a recent vaccination, ideally, you should wait for 2 weeks, ideally. And they do ask you that when you go to the questionnaire, and they'll ask you, have you had a fever? Have you been recently sick? Have you had a recent vaccine? And if you really have had one, they're going to recommend that you wait. So if your age is coming up and you think you're going to vaccinate yourself, I would wait for your tetanus, right? Or I'd wait for the booster. I wouldn't get the flu vaccine. I'd go get your COVID vaccine first, and then later on get the other things that you're getting.
Okay. Can you talk about travel? Because I thought I heard that at some point they might start requiring that the CDC or someone might start requiring that you have the card that showed that you got vaccinated. So do you know anything about that?
Well, it's under discussion, I think, and under consideration, because it was talked about, like specifically in the U.S. If you're traveling domestically in the U.S., should you have proof of that you've been vaccinated against COVID-19? And I don't think there's any final word on that yet, because obviously you can imagine people are going to be up in arms, and it's going to be controversial. And there are several stakeholders that may not want that. The airlines may not want it. So it's being discussed, but there's no final decision on that.
Okay.
If you're traveling internationally, obviously your destination has rules and regulations about who enters, how you enter, if you quarantine. You need to have a negative COVID test when you enter, documented, and maybe proof of vaccination as well. But every single international destination will have an issue like that. Well, will have their specific rules and regulations that you have to be sure that you review and abide by before you get on the plane.
Okay.
The domestic issue is still up for discussion.
Okay. Mr. Wayne has his hand up.
Yes. My question is, I seen on one of the slides where they said, where you showed, I think it's 775,000 people got the first dose, and then it literally dropped off to half on the second dose. My question is, if they didn't take the second dose and they had to start back over to get the first dose, is there any risk, or is there any risk to now you're taking the first dose twice to get to the second dose? And is there a period of time that you have to wait after missing the first dose or missing your time slot to get the second dose for you to wait to go start the whole cycle all over again?
Okay, so that's a great question. So the reason why there is that big difference in the numbers is because both Pfizer and Moderna, there are 2 doses. So and there's going to be a gap in terms of when you're going to say if persons are fully vaccinated, because for the Pfizer, there's a 21-day gap, and for Moderna, there's a 28-day gap. So really, that's why you're seeing that big difference in the numbers, those 2 numbers. And there's always going to be that difference because it's really 2 doses. So when you look at those things, it's really who's fully vaccinated. And that 333,000 are those who've gotten their 2 doses. That month have passed where they've been vaccinated. But the second part of your question is, what if you get your first dose and you don't go back for the second one? And I think the current recommendation is go back as soon as possible to get that second dose, no matter what it is, that 21 days or the 28 days. And what happens at the site is after you've gotten that first dose, there are persons there really right there helping you to get registered for your second dose of Pfizer and Moderna vaccine. Because what we don't want you to do is get the first dose, walk out the door, and then you don't schedule the second one. So really right then and there, schedule the second dose. Right, and I'm not really aware of a day to tell you like if 21 days or 28 days have passed, don't get it. I think the recommendation is if you've gotten Pfizer or Moderna, it's a 2-dose vaccine, go get the second one as soon as possible. If you've missed the 21 days for the Pfizer and 28 days for the Moderna. The good news is if you don't want to get 2 shots, you have the Johnson & Johnson vaccine, which is 1 dose, right? It's 1 shot, it's 1 shot in the arm. And I think that will increase compliance with getting that vaccine. So the difference between this vaccine, it's 1 dose. I'll talk about the efficacy. So it's 77% or say 80% effective from you getting serious coronavirus infection versus Pfizer, which is 94, 95, and Moderna, which is 95%. What they don't tell you, though, that 77% number is that the Johnson & Johnson vaccine is reportedly 100% effective against being hospitalized from coronavirus infection and dying from it. So to me, that's still fantastic, because really, even if you become infected, if it's a 100% effective against being hospitalized and potentially dying from it, I think that's really a good, still good, versus a flu vaccine, which is only 55% effective. Right. So I wouldn't be too much concerned about the 77%, and that's really for serious infection, but it's still preventing hospitalizations and deaths.
So I'm just so the second part, kind of the second 2.1 was if you have to go back and get take the first dose again, is there any study of side effects of now you're taking the same dose twice?
I'm not aware of that there's any study that says there are side effects.
All right, thank you.
You're welcome, sir.
Mr. Roden, I see you have your hand up.
Yeah, good evening, everyone. Just trying to learn about the anti, you know. Having me. I'm scheduled for my vaccine on the 11th, but I'm also scheduled to do my physiotherapy. As you know, I'm trying to get back on stream. The vaccine's supposed to be 2 o'clock and the physiotherapy is 3:30. What is your recommendation, Doc?
So, well, first, you should talk to your doctor to get the advice, right? Your personal advice. But your vaccination is really, really important. I would do the vaccination, and I'd ask your physiotherapist if they could change your appointment to another day or later on. Because really what's going to happen beside of at the 2 o'clock, you have to go in and register. There are probably people in front of you, right? Verify your information, get your vaccine, and then you have to sit there for at least 15 to 20 minutes after to be sure you don't have an allergic reaction. So it's not like you're going to run in and you're going to be out of there in 15 minutes. Typically, you're probably going to plan on spending at least an hour just to be in the site, to get through the line, get registered, get your vaccine, and then wait to be sure you don't have any side effect. So, and then if you're you're going to be running up against time. You're going to typically probably have, I got vaccinated and I didn't have any symptoms. I knew that I got a shot in my arm. I didn't have any pain. I didn't have any soreness. I didn't have any rash or anything like that. Some people get that. They get pain, they get some soreness in their arm. If your physiotherapy is going to be doing something with your upper arm, I think I would say you don't want to do that same day. So potentially, if you could, I would change the time or change the date.
Thank you very much.
You're welcome, sir.
Vaccine, I have been where I've seen, I was like one of the first patients in my institution to ask for that mask. So I can tell you from personal experience, I've seen people died from the COVID. I also got the COVID first. I got COVID already. And I still, if I'd asked for the mask, I would not have got it. So it's real. So nobody don't have to tell me if I wonder what's going on. It's there. So I rather die with the vaccine. So that's my first priority. Everything comes after, you know.
I agree.
Thank you.
Thank you.
Mr. Errol, you have a question? Can you unmute?
Hi, Gary.
Hey there, our President. How are you doing?
I'm good. So with the vaccine, in terms of, follow-up, so the science is, will we need vaccines next year again? Or once we get these one shot, we're good?
That's a great question. So based on what we know now and what we're seeing with the variants, I think it's going to be most likely you're going to need a booster. You're going to need a booster of some sort. Specifically maybe for the wild type, the one that's common, coronavirus, as well as for the variant. And the one thing you must remember, right? So with the studies, no one can tell you that once you've gotten those first 2 doses, you're immune for life, because we don't know that yet. It may be the case that those doses will make you immune for life, but I think based on what we know, you're probably not going to be immune for life. So you're probably going to need to take a booster. As well as the fact that you have these variants popping up, you're going to need something to fight against that. We don't know right now how effective those are against the UK, Brazil, South Africa, whatever else, California, New York, whatever else is going to be coming down the pike.
Okay. Other question. So someone who already have a virus, right? and they have the virus. So obviously they have, I would think they have some antibodies in them from the virus. So for those people who have the virus, have the antibodies, now they're taking the vaccine, right? Are they more protected, like someone like myself who never had the virus and just getting the vaccine first time? Because they have the antibodies that's there naturally plus the vaccine. So are they in a better position to avoid serious infection or not getting it again than someone who's just like myself taking for the first time?
Right. So I will answer theoretically and an answer in saying that we don't know. But you would assume that if somebody has natural antibodies, natural immunity, and you're getting a vaccine, that's basically boosting your response, kind of making your body, a secondary boost, basically. You would kind of think theoretically that that person is more protected because they've had the natural immunity boosted by this vaccine. So you would think theoretically that's the case, but I don't think we know that answer. But then again, but you would also say really the reason to take the booster probably a year or 6 months from now is for that same reason. You've had, your body's made the antibodies and we want to boost the response. So getting a booster, which is just like the DTaP, the boost of the tetanus, that's what it does. But your body has what's called memory cells, and it kind of remembers. But so to answer your question, I think the answer is probably yes, that if you had the natural immunity, the vaccine probably boosts it and makes you more protected, but I don't think we can say that for sure.
Okay.
Um,
Thank you.
Thank you. We have a question. Would you recommend that the elderly with multiple
comorbidities?
Yes, have the Pfizer or Moderna vaccine instead of the Johnson & Johnson?
The studies with Pfizer and Moderna included persons who had comorbid conditions, and that was deemed safe to have an elderly person with comorbid to take it. So it wasn't 100%, and I forget, because I pulled, if you go to their website, they'll tell you how many persons with comorbid conditions, diabetes, hypertension, HIV, that were in their studies. And so when the FDA looked at it, it was felt that it was safe enough to give persons who are both elderly and or with a comorbid condition. So the answer is yes. I didn't look at the J&J's data in terms of how many persons with comorbid conditions were considered, but I would think the answer is yes, because if they got the EUA, most likely they did. So my answer is either whichever vaccine is available to you, I think I would take it anyway. I would take it.
Okay. Thanks. Here's another question. What work is being done around how long a vaccine will last? Do you know what the projections are?
I don't know that answer. I mean, every day, really, what I do, or you can do, is I go to the CDC's website for the particular vaccine manufacturers. You can always go to their website and pull their studies and kind of see what they're saying. I don't have the answer for that. I don't even think they know, really.
Mm-hmm. Okay. Do you have any thoughts on with the government relaxing some of the precautions they had in place? Any words of wisdom?
Well, this is what I would say. I mean, I think by now we know that this infection spreads. It's airborne, right? It's airborne. It spreads by respiratory droplets. It spreads when you talk, when you sing, when you breathe, when you touch surfaces that are infected. And so to me, there's like no debate that's how that happens, right? I've known people who have died, who have gotten sick, who've died from it. I mean, I don't think there's any debate that, because before people were saying it's a hoax, people aren't dying, the hospitals are not overrun. That's just not the case. We've lost 500,000 people in the US. That's 500,000 people. People have died, people are sick. So if you look at how this thing is spread, airborne respiratory contact, the number of persons who've died, the strain on the healthcare system, people who don't, die because of a lack of oxygen, a ventilator, medications, there is no way. I don't understand why you would open the economy and not say to people, you have to do these prevention. You should wear a mask. You should social distance. You should sanitize. And I understand that businesses got to get back to, making money and being in the workplace, but I don't think you can do that without the other things. And you have to use vaccines. So I scratch my head when I hear that. I'm like, okay, I'm not sure what's going on.
Okay, so two more questions. This one, and then Mr. Caswell will have the last one. But this one is, with people wearing the masks all the time, you're breathing in your air and it gets sweaty under there. Do you think there's any cause for people who have respiratory problems to develop any respiratory issues because of wearing the mask for many hours and, breathing in the air, you're sweating?
I don't think of any studies that I'm aware of says that there is a problem for most people, because unless you're working in a mask for 12 hours, 8 to 12 hours, and if you are, and you have respiratory issues, I think you can ask your supervisor, your boss, your workplace for some accommodation so you can be in a place where you don't have to wear the mask for 8 or 12 hours. So if it's in the workplace, I guess I'd ask for accommodation. I'm not aware of anything that says specifically it's an issue. I mean, the guidelines do say if you have chronic respiratory problems, some medical issues that prevents you from wearing a mask, then you shouldn't, but then really you should be home. Because if you do that in public, if you get infected with your chronic respiratory problems, you're going to be in trouble. You just think about like surgeons and nurses who wear a mask for 12 hours a day and they're breathing in stuff. I guess the question is, well, if they have a respiratory issue, but it doesn't drop your oxygen. Surgeons work in a mask 6 hours, 8 hours every day for 40 years. And they don't have an issue with them, but I guess specifically, if you have a chronic respiratory condition where you're forced to wear a mask, I'm thinking in your workplace, you need to ask your supervisor for accommodation, or you probably need to be home.
Okay.
Mask off.
Okay, thank you. Mr. Caswell, you have the last question.
Yeah, so asymptomatic. If one, well, I'm not sure to put. Okay, so you're asymptomatic, or you don't know if you went and did a test. Is there a special test to determine if you're asymptomatic, or when you do that COVID test, that would tell you if you were? Because it's known that people are carrying the virus, but you don't know. I'm sure at some point you're going to get over the COVID if you're asymptomatic, just like if you got it normally. So how would one know if they had it?
Right. So So the way that you've known if you've had COVID and gotten over it is doing a blood test called the antibody test. It's a blood test that you would do to see if you've been exposed and recovered from COVID-19. But we don't do that test routinely. So we don't do that test routinely. When you go for your vaccines, we don't do that test routinely. Your doctor's not going to be drawing that test to see if you've had antibodies, natural immunity from COVID-19. Typically, that's not being done routinely. if you are concerned about you've been infected with COVID-19, you can still go to you can still get COVID testing, the nasal swab, the oral swab, and you can do the antigen test, which is commonly done, or the PCR test to see if you've been exposed and infected with COVID. That doesn't tell you if you've had it and recovered. But at this point, for most of us, I'm not even sure the antibody test that's going to tell you if you are asymptomatic and you have natural immunity is of any value to you. Really, what you're going to do is you're going to go take your vaccine and then realize after you've taken the vaccine, we will assume that you're then immune because your doctor is not going to then draw to see if you have antibodies to COVID-19. Typically, that's not what's done with any vaccination. We assume that if you're not on a chronic steroid or immunocompromise, that naturally, once you've gotten the vaccine, your body is going to respond and make enough of it to protect you. Unless at some point then it becomes a concern, then we will try to figure it out. But for the most part, that's not done.
Okay.
Thank you.
If I can say something,
Hi, go ahead.
I was just to answer casual question, and a quick way to do it. Like the American Red Cross right now, when they take your blood, if you donate blood, they do an antibody test. So if someone is, like for myself, I'm getting the vaccine on Thursday, but I'm giving blood tomorrow. So it would tell me as of tomorrow if I had the COVID before COVID. Because I had friends that gave blood, and they found out they had antibodies. So at some point they had the COVID, and they were obviously asymptomatic, and they didn't know. So I gave blood about 6 weeks ago. Came back saying that it was negative for antibodies. So I'm gonna give blood again tomorrow, and within 3 days they'll let you know, if you had antibodies. So that would probably indicate that I had COVID at some point.
Were you vaccinated?
I'm not yet. It'll be Thursday. I'm taking my first shot on Thursday.
Okay.
Yeah.
Okay. I'd like to thank you, Dr. Rhule, for this very informative discussion. You had lots of questions tonight, and you provided a lot of information. Okay, so thank you, everyone.